So we have a 40-year-old gentleman who works as a sweet shop owner from West Bengal. He presented with complaints of painless, fresh bleeding per rectum for the past 3 to 4 years and loss of weight in the last 3 to 4 months, which was not very quantified. So he had 4 to 5 episodes of every month with about half a cup of blood. It was before and after passing stools. It was not mixed with the stools. He also had occasional burning sensation in the perianal region. He complains of about 3 to 4 kgs. He's not very sure in the past 3 to 4 months and no loss of appetite. There's no loose stools or abdominal pain. There's no history of jaundice, abdominal distension, no chronic cough or constipation, no fever, chest pain, or any other systemic complaints. And in terms of past history, he has no previous known comorbidities, no surgeries, or hospital admissions prior to the onset of current illness. He consumes a mixed diet. He smokes BDs and chews gutka. He is also an occasional ethanol consumer with no history of any high-risk behavior. So on examination, his general examination vital signs were normal. He was noted to be pale, and there was no hepatosplenomegaly or any other abdominal findings except for internal hemorrhoids noted at 1 o'clock, 5 o'clock, and 9 o'clock position with skin tags on the per rectal examination. Rest of his cardiovascular, respiratory, and CNS examination was normal. So coming to his investigations, he had a hemoglobin of 6.2 with a low MCV, microcytic anemia, with reticulocyte counts with a corrected retics of 1.84, a low iron, high TABC, and transferrin saturation of 5%. So he was diagnosed with an iron deficiency anemia. The other substrate, vitamin B12 and folic acid, were normal, and the LFT and LDH and all were not indicative of any hemolytic process. His other investigation-wise, the stool routine parasites grew entamoeba histolytica. His bloodborne virus screen, syphilis screen were all negative. His gas, so in terms of finding these hemorrhoids with bleeding, which was significant, and there was slight thickening of the rectal mucosa, which we felt on PR, we proceeded with the colonoscopy, which showed internal hemorrhoids and a rectal prolapse. So they had taken mucosal biopsies in view of this rectal prolapse, and that actually showed features of suggestive spiroketosis in the colon and the rectum. So actually, I'd like to talk about intestinal spiroketosis, which is actually a relatively rare case. Epidemiology, the etiology and classification, the clinical presentation, and the treatment. So actually, the prevalence in Western countries is said to be between 1.1 to 5%, and it's thought to be spread by the fecal-oral route. So therefore, they postulate that it is much higher in the developing world, but we don't know the exact numbers. And in homosexual men and HIV positive individuals, it's found to be much higher, almost 54%. So that's why they think that sexual transmission is also a possible route of spread of intestinal spiroketosis. If you actually look at the etiology, it's defined as the presence of filamentous non-treponemal spirochetes. Basically, if you see the classification of the spirochetes, there are Spiroketaceae, Leptospiraceae, and Brachyspiraceae, of which we are all quite familiar with Spiroketaceae and Leptospiraceae. But the commonest genus which causes this is Brachyspiraceae. It's actually the Pilosecolli and the Alborgi species which are known to cause this, mainly in the large intestine. So we actually see, so these spirochetes have been described in the stool all the way from Anton von Leeuwenhoek. One of the animalcules he described was thought to be a spirochete. But for the first time, Harland and Lee in 1967, they described a forest of organisms on the surface of the epithelium of an adult patient with chronic diarrhea on the electron microscopy. And so what happens is the spirochetes actually adhere to the brush border mucosa, causing it to become thickened. And the histological appearance is the only way to diagnose this. There is no they've done a lot of tests on stools and everything. It's found to be quite common actually in the population. So it's very difficult to diagnose unless you have a symptomatic patient with a colonoscopy which shows this. So that's considered the gold standard for diagnosis of intestinal spiroketosis. Actually, in the veterinary population, especially in swine farmers and all, it's quite associated with this porridge diarrhea. Like we say rice water diarrhea for cholera. In veterinary science, porridge diarrhea is what they're known to cause is intestinal spiroketosis. But in human beings, it's quite unknown as to the significance exactly. So even now, the gold standard method remains the histopathological assessment, because all the genetic tests, the PCR tests, all that can be now present even in normal individuals. So these are actually not pictures of our patient. Unfortunately, I couldn't get those pictures, but this is how it looks. If you actually see the spirochetes, they're all over in one line there. And if you actually see the silver stain, you see this entire brush border epithelium, this blackish discoloration here is all the spirochetal, which is lining the entire epithelium as a second brush border. So the problem with intestinal spiroketosis is that the clinical presentation varies significantly. They may be asymptomatic, present with non-specific symptoms such as abdominal pain, diarrhea, or rectal bleeding. So we actually see this is one study done in 2015, which shows that it's associated with eosinophilia and irritable bowel syndrome in Sweden. Another one shows that it is associated with sessile serrated adenomas and polyps. And this case series, what I want to highlight, this was published in 2021 from Pakistan. It's a case series about intestinal spiroketosis. Basically, the gist of it saying everything is association, association, association. We don't have a 100% confirmation that this causes disease. So this is that case series from Pakistan. We actually see there are competing etiologies for almost all of it. There is an abdominal TB, there's rectal polyp, there's abdominal TB in another, and celiac disease. Traditionally, intestinal spiroketosis is thought to be a disorder of childhood. That is, children seem to develop this invasion of the spirochete into the mucosa and develop disease. But increasingly, in all these case reports, if you see, the age group is getting much older. And the clinical presentation is very varied: weight loss, rectal bleeding, loose stools, and so very varied clinical presentation with competing etiologies. So we'd actually consulted ID. The reason why we chose to treat this patient was, one, it was symptomatic. Two, there was a rectal mucosal prolapse present. So in the setting of a structural change within the colon and this chronic weight loss with the bleeding, even though there were internal hemorrhoids, for all these reasons, we chose to treat our patient because it was thought to be a possible contributing factor in this patient. So the take-home point side poses a management conundrum because we don't know exactly how much to attribute to the disease. Almost always there are associations of some other disease along with it. Even our patient had entamoeba histolytica, but that doesn't explain this profound rectal mucosal prolapse without constipation or any traditional risk factor. It's often associated with other competing etiologies, so very difficult to attribute pure causation. There are no formal treatment guidelines, both for symptomatic and asymptomatic patients, but the recommendation is 10 to 14 days of metronidazole TID. So that's what we treated our patient with. And for symptomatic patients, where we cannot identify any other cause and maybe structural disease, treatment may be beneficial to the patient. So our patient received 14 days of metronidazole and he's planned for follow-up on OPD basis. The only symptom which we saw resolved was that the pain had come down a little bit. The internal hemorrhoids will probably need surgical management at a later date.
Thanks, Dr. Vineeth. Just a question. I mean, so this internal hemorrhoids is because of the infection, or he had something which
we think the mucosal prolapse is causing some venous stasis there, sir. But the cause of the prolapse, we don't have a clear etiology, and the biopsy was showing partial invasion of this internal.
Do you think, do you reckon that this is more in immunosuppressed patients?
Yes, sir. But he didn't have any feature. He's not a diabetic. He didn't have HIV. Yes.
From whatever you showed.
Yes, sir. So classically, it's in children or in adults with immunocompromise where up to 50% increased prevalence.
When do you suspect that? I mean, what?
There's no proven. So only, even the endoscopic studies that I went through, many of them have described the gross findings as normal. Only on the biopsy, when there's invasion of the spirochete into the intestine is when we can suspect that it's possible.
So if you don't do a colonoscopy, you miss.
No way to. The PCR tests and all are very common. Apparently, stools of normal people also seem to have it positive. It is a colonizer in most people's gut. So it's only because of the invasion that we considered it as a.
And I think the prevalence presumably should be more in
developing countries.
It's just that we don't look for it, yes. I guess. Any questions from the floor?
You need to do a deep colonoscopy and biopsy to see the patients that is.
There's no guidelines about the treatment. Even the antimicrobial regimen, there's no guideline.
Would you do it?
So I would say that we'll wait for his main complaint was the bleeding. We've still not addressed that. So after the surgical hemorrhoids are treated, if he still has a problem, then possibly.
Problem as in bleeding.
Bleeding or any other, or the rectal prolapse, whatever. After management of that, if he comes back, I would probably consider doing a colonoscopy.
In the case of the infection, these patients have that severe anemia also associated with disease.
I didn't actually look at that. I have not seen that. This is what they described. I didn't look at the anemia part.
Any long-term complications?
Nothing is following up is there, sir. It's all case.
Interesting. Any other questions? Anyone online? No. Thank you, Dr. Vineeth. And we move on to the fourth one, maybe the fifth one. Yeah. Medicine 4, Dr. Krupa, will be presenting masquerade.